So, Nick, on to menopause and anxiety, which is probably the most common symptom that certainly I hear when I'm working with women, and within our sort of support community, it's the one that probably is the most troubling for those who have tried or are using hormone replacement therapy. So they've optimized their lifestyle, they're exercising where they can, they've looked at their diet, they've reduced their alcohol, they've tried HRT, they're probably still on HRT, but they're still experiencing either anxiety or what they would probably call sort of the mental health symptoms of menopause. And it's certainly not a majority, but there is a small majority who have some relief using HRT for other symptoms, but it doesn't help with the mental health symptoms. I'm sure you see patients, I'm sure over the years you've seen patients in your clinic. How would you go about helping those patients to manage those symptoms? What would you be doing? Because many of the women that I see and speak to are obviously under their GP, they're not under a specialist. So what would be your way of helping with that?
Well, I think you'd be the first to agree that for this reason, what we need are biopsychosocial approaches to the problem, and that hormone therapy isn't always the solution. Um, and that's why I always say, whatever hormones or other pharmacological options we throw at it, it's important that uh, it's underpinned by optimizing lifestyle, diet, exercise, relaxation techniques, and different people find different techniques helpful, be it mindfulness or yoga. CBT can be very helpful for some women. Um, and we have a multidisciplinary, holistic approach to the problem. Now, some of the clues that there may be a hormonal basis to the anxiety and mood symptoms is whether that individual suffered with premenstrual syndrome during their menstrual career, so to speak,
Mm-hmm.
or postnatal depression or postnatal mood changes. And then perimenopausal, as the periods start to become a bit more erratic, mood changes. Um, and it's often in that same predisposed sort of individual who was actually very well, for instance, during pregnancy when hormone levels were high and stable. The other thing to do is, if it's somebody on HRT already, is to make sure that they're on the optimum hormone therapy regimen, which in my view is not going for the synthetic types of progesterone, but the natural type of progesterone, which has a calming effect rather than a negative mood effect.
That would be the
Sometimes
micronized progesterone.
micronized progesterone, yes, an example of which is utrogestan. Um, it's interesting that some women who have side effects from the progesterone get less side effects if they insert it vaginally.
Yep.
But those women that have anxiety do better with it orally, because oral administration leads to conversion to allopregnanolone, which is the pharmacologically active hormone that then acts on the GABA receptors, the receptors in the central nervous system that have this calming effect. But also, apart from progesterone, estrogen is an important hormone, and it may be that the dose of estrogen isn't high enough. And I find that women who often have low mood do better with higher doses of estrogen. But there are a small group of women who find that too much estrogen makes them more anxious.
It's so interesting, because that was
So
just what I was going to ask
so
you.
that's where you need to define in that individual their optimum therapeutic range, below which they get symptoms, and above which they get side effects.
Yeah.
And for some, that therapeutic range can be quite narrow.
Right.
And that why it can be a challenge. And you also know that, we've seen patients who are given ever increasing doses of estrogen, so that then their estrogen receptors switch off, what we call tachyphylaxis, and so it doesn't work at all. Mm. And then sometimes the missing ingredient can be testosterone. Testosterone is an important female hormone. And in those women, for instance, where they're also complaining of lack of sexual desire and arousal, which is the sort of typical testosterone deficiency symptom. Mm-hmm. That can be a clue that the anxiety may be related to psychosexual issues as well, and they may benefit from some testosterone supplementation. Mm. So I think it's about bearing in mind, this holistic approach, bearing in mind the whole armamentarium of approaches that we can use sort of medicinally and in terms of psychotherapeutic approaches to get the best outcome in each person.
Mm. And Nick, would you ever consider antidepressant medication alongside hormone replacement therapy? Or would you be perhaps referring on to somebody who specialized in that particular area as part of your multidisciplinary approach?
I don't think we should exclude antidepressant medication. I think there has been, and I'm sure you'll agree, perhaps too much prescribing of antidepressant medication for treating menopause symptoms in general, not just anxiety.
Yeah.
So for me, first line in terms of medicinal approach will be a hormonal approach. But sometimes you can see a synergistic benefit by giving an antidepressant at the same time as hormone therapy. And in that instance, I would tend to go for one that's less likely to have side effects like anxiety. Citalopram seems to be quite well tolerated. Escitalopram is another one I have more experience in using in my patients. This also applies to women with premenstrual depression and anxiety, that they can do quite well with luteal phase sort of SSRIs, antidepressants. But I also think it's important that we work with our psychiatric colleagues. And the colleague that I probably work with the most from a psychiatric perspective in menopause and PMS, PMDD is Michael Craig.
Yeah. He's at the Maudsley, Nick, isn't he? Is he at the Maudsley?
He's at the Maudsley, yes, and runs what he refers to as a psychoendocrine clinic. And he actually is duly qualified as a gynecologist, although the gynecology side of things was quite a while ago.
Right.
But I've heard him refer to himself as a gynechiatrist.
Yeah, I've heard that too.
It's about utilizing each person's expertise and strengths so that we can reach, find solutions in what are complex situations. Because there's no doubt that menopause can have a huge amount of profound effects by itself, but there's no doubt that it can also exacerbate pre-existing conditions. So people with pre-existing depression or anxiety disorder, people with psychoses, people with ADHD, that's been sort of linked recently as well. Autism, autistic traits. So, it's about understanding all of the factors which go to make up that individual woman's personality and their the potential response to each intervention that we give them.
Perfect. Thank you so much.